This program is brought to you by Emory University.
All right, well, good morning. Thank you for being here. As you can see, our speaker this morning is Alex Sommerfield. Alex is one of our third-year fellows in the clinical track. Alex is a native of the greater Orlando area.
South Florida.
South Florida, sorry. South Florida, somewhere in Florida. Johns Hopkins undergrad, University of Florida for medical school, University of Pittsburgh for residency, and he is doing some training in imaging this year and is out on the job hunt looking for general cardiology / imaging jobs right now, and he's going to talk to us about cardiac CT today.
Good morning, and thank you guys for all being here today. So today we're going to talk about cardiac CTA, specifically really focusing on coronary CTA as kind of an overview for the general cardiologist. And my goals today really, one, to highlight the basics and fundamentals of cardiac CT and image acquisition, to review provider considerations and what are the limitations to cardiac CTA. I'm going to examine the evidence of coronary CTA in a stable CAD population, as well as in the context of acute chest pain. And along the way, we'll review appropriate use criteria from the standpoint of coronary applications. And so here's the goal of what we're really looking for, a test that is giving us clear, unambiguous evaluation of the coronary arteries, where we're able to definitively exclude coronary disease, but also where we're able to identify high-risk disease. Here on the image on the right is a proximal LAD, kind of calcified and non-calcified plaque with severe stenosis. And so we're really trying to identify those patients that are going to most benefit from revascularization. And obviously doing that in a safe and a way where we're minimizing radiation dose as much as possible. And so what are those requirements that enable us to find that and get those images? Well, we need high temporal resolution. Coronary and heart motion has to be minimized in order for us to get that level of detail. We're also imaging very small structures that are coronary arteries in the range of 1 to 4 millimeters in size. And so in order to do that and manipulate through multiple planes, we need to have what we call isotropic voxels to adequately assess the coronaries. And again, doing that all in the context of minimizing radiation dose as much as possible. So I want to review just a little bit about the basics of cardiac CT in general and kind of the fundamentals. And so here's kind of your basic anatomy of a single source CT scanner. First and foremost, we've got your X-ray source, the X-ray tube, the pre-patient collimator, kind of limiting where you're focusing the X-ray to a specific part of the body, and then the detector array. And so the X-ray tube, it's really acting as where X-ray production occurs. And so what that is you have a heated filament that's emitting electrons, and those electrons are accelerated by a voltage potential, and those electrons are hitting the anode, and that production and interaction of electrons with the atoms on the anode is what produces X-rays. And so with that process, there are a spectrum of X-ray energies that are created during X-ray production, and different levels of absorption, or what we call attenuation by biological structures, are what lead to the discrimination of objects on an image. And so when we look at attenuation, it's specifically inherently dependent on, one, the substance that the X-rays are passing through, but also the energy of the X-ray. And if all X-rays were absorbed, you would see a whiteout. If all X-rays were transmitted, it would be black. And so the X-ray detector is really the photon counter. There are hundreds of these detector elements within a single row, and each row is generating that detector profile. And I think one of the advancements in cardiac CT has been the advent of 320 slice, 128 slice CTs, where you're really getting excellent detector coverage, meaning, if you have thin slices, which is what we require in cardiac CTA, with a 320 slice scanner, you're imaging essentially the entire heart within one rotation of the CT gantry. So again, really the thing that we're aiming for are thin slices and wide detectors. When we talk about, again, isotropic voxels, we're looking for the same dimensions in the X, Y, and Z plane, because as we are analyzing coronaries, which are going in and out of multiple planes, you get a lot of image distortion when you lose the isotropic voxels. And so this kind of nicely demonstrates when you go from a 5 millimeter slice thickness to a 0.5 centimeter slice thickness, how the image quality changes, and how that's essential to really evaluating the coronaries accurately. A couple important points to take note are concepts of contrast and noise. When we're talking about contrast here, we're talking about radiographic contrast, and so we're talking about the difference in attenuation between two different structures. So looking here at the coronary artery versus, epicardial fat, being able to discriminate two structures that are very close by is important. But also the noise or the inherent scatter within a specific structure that should be homogeneous is going to be crucial to, accurately evaluating coronary arteries. And so our goal is really having a high contrast to noise ratio. And clearly we can see that very nicely on the scan on the left. Not so bad on the right, but certainly a lower contrast to noise ratio than on my left. So back to kind of the concept of the importance of freezing cardiac motion. I think this is a nice picture that nicely conveys that, where you can really run into a lot of problems if you don't have that. And, a study can essentially become non-interpretable in that. And so that brings upon the concept of temporal resolution again, which to me, I think of it as kind of like the shutter speed on a camera. It's the amount of time that's required to acquire an image. And it's essentially dependent upon the gantry as the X-ray detector, as the X-ray source rotates, it's the time it takes for it to rotate 360 degrees. Now in CT, we actually only need 180 degrees of data points in order to get to reconstruct an image. And so really our temporal resolution is a product of the gantry rotation time by 2 in a single source scanner. But we also have dual source CT scanners now, which you have 2 X-ray sources, 2 detectors, and so the temporal resolution in those systems is actually just 1/4 of the overall gantry rotation time. In modern CT scanners, or with dual source CT scanners, we're getting temporal resolution on around 70 milliseconds. In order to actually freeze cardiac motion at any point in the cardiac cycle, you need a temporal resolution of 50 milliseconds. So we're not quite there yet, and certainly we are well below what the temporal resolution of invasive angiogram is, which is at about 10 milliseconds. And so because of that, really we have a crucial aspect that we need to review, which is ECG gating, and that's really what separates cardiac CT from other types of CT scans. And so unlike the way we think of the cardiac cycle in cardiology, really the start of the cardiac cycle in CT is with the onset of the R wave, the QRS. And so this is a depiction of really showing where coronary motion is minimized. And so our sweet spots of where we're really looking to find where we're freezing cardiac motion as much as possible is in this 40% window, which is end systole, and around 70% in diastole, kind of during isovolumetric relaxation time. And this is a nice echo correlate of that concept, and it really, I think, brings to home the importance that heart rate control plays, where here you have a heart rate of 59, and this is that sweet spot where we're really trying to image the coronaries and get those beautiful pictures. But, you know, just slight variations in increases in heart rate can really decrease that time to where the sweet spot becomes that 40% interval. And which will bring me, I'll get back to that and why that's important a little bit more in just a second. But we have different types of how we acquire CT data. The first way, and the kind of original way, is retrospective ECG gating. So essentially what we're doing, we have an X-ray exposure. It's continuous. We're scanning the patient from onset of the R to the RR interval, the entire phase, 100% of the time. That obviously creates higher radiation dose. A lot of that information is not helpful in coronary CTA. But we go back and find the spots that we want to select to use for image reconstruction. Kind of the opposite to that, or the other method that I think is kind of the ideal method, especially with a wide 320 slice CT, is prospective triggering. So in this scenario, we're actually turning on the tube, the X-ray source, only during specific parts of the RR interval that we select beforehand. This significantly reduces radiation dose. The downsides to this, you lose functional data, which I think in an evaluation of coronaries is less important. We have other ways of acquiring that information, but certainly one of the downsides. And the other thing that's really important is it's a one-shot deal. So you're only imaging at one portion, and if you really miss the sweet spot, you're kind of left dealing with images that are going to have cardiac motion in them, which can be difficult to interpret. So the factors that help us, that favor prospective triggering, again, having greater detector coverage, where it one beat and you've scanned the entire heart. Lower heart rates, again, where you're getting that sweet spot in diastole to image the heart, and regular heart rates, arrhythmia, AFib, those can be much more challenging to use prospective triggering as opposed to retrospective gating. And again, just to kind of highlight that point where you can see, radiation dose can be significantly reduced, 80 to 90% in that type of ECG gating. Those aren't the only types of ECG gating, and I think this is projecting okay. So we've talked about retrospective. This is another type of a retrospective, what we call ECG tube current-based modulation, where during those parts that we're really interested in, were the tube current, which is where we ideally want it to get the best pictures, but then we lower that current, but it's still on, but it helps reduce that radiation dose. It still gives us functional information, and so you kind of get the best of both worlds in that domain. Again, prospectively triggered scanning. And then there's also this concept that we commonly use, especially when someone comes in, say as an outpatient for a coronary CTA, and their heart rate's 90, and they get some beta blockers, but you're just not able to get their heart rate down to 50, 55, where we increase the padding. So we actually scan them from 30 to 80% of the RR interval. So we're cutting out some of that radiation exposure in order to really be sure that we're getting the information that we need. And so kind of my take-home points from from the CT basics and fundamentals is that X-rays are attenuated by biological structures. Our CT detectors are the photon counters, which are able to calculate the attenuative property of structures in the scanner, and that differential attenuation of structures is what gives us images. Thin slices allow for isotropic voxels, which enables us to analyze those small structures like coronaries through non-traditional and oblique planes. Adequate temporal resolution and ECG gating are important elements to successful coronary CTA, and the type of scan mode can have drastic impacts on radiation dose, and really it's the type of scan mode that you're using should be determined based on your clinical question and the underlying heart rate and rhythm. So other considerations for a successful and safe scan. Obviously looking at comorbidities, renal function, someone that is coming in with a creatinine of 2 for, chest pain and a coronary CTA, it's probably worth revisiting. Is that the right test for that patient? Obviously making sure, and aware of any kind of contrast allergies and allergies in general, and certainly comorbidities. We'll get to kind of the where CT kind of shines and where it's best used, but certainly a patient that's 75 with diabetes, peripheral vascular disease, stage 3 CKD, and has a high pretest probability of coronary disease, CT may not be your best first option. We need a larger bore IV above the wrist. We're really trying to give a high bolus of contrast, and the higher the rate, the better, because we get better enhancement, which is what I was trying to show here in this graph. They need to be able, a patient needs to get adequate training on breath holds, because just like cardiac motion, respiratory motion can cause significant problems in interpreting a scan. And always reviewing the rate and rhythm and the EKG prior to the scan. Beta blockers are commonly used, and it's critically important to have a good established beta blocker protocol in place. And there are obviously considerations where we need to be cautious with those medicines. Probably, I think once or twice, in this last 3 months on imaging, we've had someone that, had an echo the day before that showed a newly depressed EF, and their heart rate's 110. And that's not the right person to just go willy-nilly and giving large doses of beta blockers. And so always being mindful of those considerations is important to having a successful scan. And so coronary CTA, it's uniquely good and probably our best test at excluding obstructive CAD. It has an excellent sensitivity and negative predictive value. The downside is our specificity and our positive predictive value are not as good. We're overestimating stenosis severity frequently on CT. The correlation of stenosis on CT to Cath is not as good or as accurate, and our ability to evaluate ischemia based on coronary stenosis on CT is also not that good. And so what are some of the things that create that problem of reduced sensitivity? Motion artifacts, again, I think I've kind of discussed a little bit so far. Pulmonary motion, beam hardening, and blooming artifacts are other scenarios. This is actually an example of beam hardening from a pacemaker lead. So motion artifacts, cardiac motion, again, appreciating here, scanning in late diastole where we normally acquire data, and if you did a prospective study with from 70 to 80, this would be what you're left with. But in this case, they either increased the padding or did a retrospective study, and here you can clearly see the right spot was at end systole, and you have a perfectly normal coronary artery. Breathing, respiratory motion is also a major problem. And all of our technologists will give the patients adequate training to make sure that, as we start the scan, they're taking a breath in and holding so that we minimize these problems. Kind of some of the telltale signs, you see these discontinuities in ribs. You can see blurring and streaking in the lungs, and so those can all be telltale signs to respiratory motion. The other thing that I think is the biggest problem in coronary CTA is the concept of blooming artifacts. And so really you have calcium is going to give you a high Hounsfield unit on CT. And that calcium creates a situation where any voxel, so these are all voxels, that contain any amount of calcium is effectually saturated, meaning the concept of partial volume averaging. So this voxel, which has minimal calcium, is kind of interpreted as, oh, it's calcium. And so really this is your true lumen, but this is kind of what CT is showing. And so it's overestimating the degree of stenosis severity. Again, kind of a nice picture depicting that, but here you kind of find really the problem spot isn't where all this calcium is. The problem spot is where that non-calcified plaque is. And so this is just, I think this, projects okay. What we really see is that as your coronary calcium score goes up, the diagnostic accuracy, the specificity of detecting obstructive CAD goes way down. And so there are certain places where, with coronary CTA, they do calcium scores, and if you have a calcium score of greater than 600, they say, okay, well, maybe we should stop the scan and not proceed forward. Given some of those difficulties and our the Society of Cardiac CT has a classification system that we use because, again, we're not the greatest at pinpointing the degree of stenosis, and so we have categories of disease that are outlined here. And I think it's a helpful reporting system in that it also gives the ordering provider a recommendation, particularly if this is someone that's not necessarily in cardiology, what's the next step? And so moving on, I think a common question that's asked is, well, is CCTA appropriate in the evaluation of coronary stents? The answer to that is it depends. One, it's dependent upon stent size. It's dependent upon the stent type. And it's certainly important that the reader uses what we call a sharp reconstruction kernel, basically giving us better edge detail in order to evaluate the stent. And so here, this is clearly identifying in-stent restenosis, whereas here, a smaller stent, you're finding that you're getting into a world of trouble, and when you correlate that to invasive angiography, it's fine. And so really the visibility of an in-stent lumen is dependent on that stent size. And so if you're looking to evaluate stent patency less than 3.5 millimeters, I think you're probably better considering another test. This is obviously a small study, but that's kind of a consensus. And really, in the appropriate use criteria of coronary CTA in the context of prior stenting, the only indication that gets an appropriate referral for CTA is actually someone with a left main stent greater than 3 millimeters in diameter. I think certainly it may be appropriate in someone that has a stent greater than 3, but really the only one that gets the yes, this is definitively appropriate is left main stenting. And certainly I think any patient that you're considering doing a CTA to evaluate stent patency with a stent of less than 3 millimeters is inappropriate. What about bypass grafts? This is actually kind of a nice 3D volume rendering image of bypass grafts. Here, clearly identifying a kind of a stenosis in the body of the graft. CT is actually uniquely good at the evaluation of bypass graft occlusion and stenosis. One of the reasons is because it's not subjected to coronary motion in the same way. Bypass grafts are obviously much larger, and so they're visualized easily with CT. The issue that you run into is that while they're uniquely good at evaluating the status of the graft, the downstream, the touchdown the downstream native vessel is going to be almost always difficult to interpret because it's going to be diseased, and it's often less helpful after the touchdown of a bypass graft. So if the question is there ischemia, it's probably not the right test. But if the question is, what is the status of my bypass graft, it can be very helpful, particularly in someone where you don't know where their grafts are. They're referred for chest pain and a left heart cath. You're mucking around in the aorta for 45 minutes. You give them 200 cc's of dye, and you don't fully know their anatomy. I think this is really where CT can be very helpful. And so for appropriate use criteria for bypass grafts, it is appropriate for symptomatic patients for evaluation of bypass graft patency. For asymptomatic patients, it's not necessarily considered appropriate. It may be appropriate after 5 years, but again, really the only appropriate indication is in symptomatic patients. The other scenario where bypass coronary CTA is very helpful is in preoperative planning prior to redo surgery. Say someone that's going for an MVR, a second surgery, but's had prior coronary bypass. It is very helpful in identifying the location of the lima graft to the sternum so that you don't create problems when you're cutting. It's helpful in evaluation of pump cannulation. And so I think it can be a very useful tool in that scenario as well. And so my take-home points here, really CCTA, it's a very reliable test in ruling out coronary disease, and we'll get to that more later as well. Again, it has high sensitivity and negative predictive value. It is a good option in those low to intermediate likelihood patients with concern for CAD. In those high likelihood or someone that has, multiple 2.5 by 2.5 millimeter stents, it's, not necessarily, it's not the right evaluation. And I think it is a uniquely good test for evaluation of bypass grafts. So now I'm going to transition to kind of moving beyond just discussions about sensitivity, specificity, and really examining the role that CCTA has had on clinical outcomes, first with stable CAD. Approximately 4 million stress tests each year are performed in patients that have no known history of coronary disease. And obviously, we see it all the time, non-invasive functional testing frequently leads to the inadequate selection of patients for coronary angiography, and often misses those that would benefit the most from coronary angiography. And so there has been a debate as to what's the most optimal and cost-effective way of evaluating these patients. And so the first study I wanted to review is the PROMISE trial. This was a multi-center randomized comparative effectiveness trial in the US and Canada. There were 10,000 outpatients that were enrolled in this trial with stable chest pain and no prior history of coronary disease. The hypothesis was that clinical outcomes in patients assigned to the anatomical testing arm with CTA would be superior to those assigned to functional testing. It was a 1-to-1 randomization. The primary endpoint was all-cause death, MI hospitalization for unstable angina or complication from a procedure, cardiovascular procedure. The secondary endpoint was looking at invasive cath that showed no obstructive CAD. They also looked at radiation exposure. The inclusion criteria, as above, if you were, under the age of, if you had one risk factor, as long as you were over 45, you were considered. Otherwise, if you had no risk factors, you had to be over 54. And then as follows for women. The exclusion criteria, obviously not someone with suspected acute coronary syndrome. Someone that has, they excluded anyone that had had an evaluation for coronary disease within 12 months. And then obviously, anyone that had unstable hemodynamics, arrhythmias, heart failure, valvular disease, all those. All the testing sites were kind of vetted and were certified, and they really made sure that there was good quality control in all the diagnostic testing centers. And so the baseline characteristics were similar in both groups. The average age was 61, about half were women. The mean pretest likelihood of coronary disease by use of Diamond-Forrester criteria was 53.3. So the right population, the intermediate risk population that we're really trying to further evaluate. About 2/3 of the patients that were in the functional arm underwent nuclear perfusion imaging, and then the rest either underwent stress echo or ETT. And so what we really found is that there was no significant difference in those primary endpoints in either arm. And when specifically looking at kind of a harder outcome of death or non-fatal MI, again, both tests performed equal. There was really no declared winner in this. One of the interesting things that I do think PROMISE showed is that when you looked at cardiovascular death or MI within 12 months, of the 53 patients in the CT arm, 7 of them had normal coronary arteries. When you looked at the results from functional testing, of the 72 patients that had cardiovascular death or MI, 67% of them had normal functional testing. And so I think that's kind of an important thing to take out of the analysis from PROMISE. In terms of other findings and secondary endpoints, there was a higher rate of Cath in the CTA arm than in the functional arm. I think importantly, the proportion of Caths that did not have obstructive CAD was lower in the CCTA arm than in the functional arm. And certainly the amount of obstructive CAD found was much higher than in the functional arm. And kind of looking just at the individuals that underwent Cath, 170 of 609 did not have coronary disease, and versus in the functional arm, over half that were referred for Cath ended up not having coronary disease. And so in terms of discussion and conclusion, PROMISE enrolled, I think, a good cohort of symptomatic intermediate risk patients for whom testing is recommended. There was no winner declared with respect to those hard primary endpoints. The overall event rates in a stable CAD population are low. And so there's a very good midterm prognosis. And almost half of those primary endpoints were actually hospitalization for unstable angina. The follow-up, it would be interesting to see what that follow-up looked like maybe, 5 years out. And we do have a trial, which I'll get to in a minute, but looking a little bit longer at the role that different testing strategies have on longer-term follow-up. The other thing that I think was a downside to PROMISE is there was really no data on seeing how testing influenced initiation and maintenance of preventive therapies. And so, and lastly, I think another interesting thing that would have been was if there was a third group who actually just received medical therapy based on a history and an assessment alone, but actually didn't undergo testing, and to really see, does testing have any value or benefit? And so next I want to move on to the SCOT-HEART trial. And this is actually looking at the 5-year outcomes from this trial. And so this was actually the first trial that showed that CCTA actually improves clinical assessment and outcomes in patients presenting with suspected angina due to coronary disease. This was actually performed in Scotland at 12 different centers. Essentially, all patients were referred to a chest pain center and were seen, examined, underwent a 12-lead underwent exercise treadmill testing if it was considered appropriate. They kind of formed a treatment plan, and then patients were randomized 1-to-1 either to just standard of care, which was up to the clinician as to whether they wanted to proceed forward with Cath or additional functional testing, or to CCTA. Management was at the discretion of, again, the clinician. In the CTA arm, those that had either obstructive or non-obstructive disease, there were preventive therapies that were recommended. And in the standard of care arm, they just used an assigned score, kind of similar to like a Framingham risk score, to help them guide whether preventive therapy should be initiated. And so there were about 2,000 patients standardized to each arm, and very good follow-up. The endpoints were death from MI or non-fatal MI. There were also process of care endpoints, again, similar to PROMISE, looking at rates of invasive angiography, revascularization, also looking at how how prescribing patterns changed based on CTA results. And so I think a couple of important points to take home here. I don't entirely think this is representative of the population in the US, largely because the amount of stress imaging that patients underwent was extremely low. And so really it's a comparison of CCTA to exercise, EKG, and standard of care. There really, again, were no significant differences otherwise in the CTA versus the standard of care cohort. The encouraging thing from the CT community, you would say, is that this did show a significant reduction in the primary endpoint of death from coronary heart disease or non-fatal MI compared to standard of care. And when you looked at after the first 12 months, there was no significant difference in the rates of coronary angiography or revascularization. And this is those Kaplan-Meier curves looking at both kind of the composite primary endpoint. You can certainly say that the primary endpoint was largely driven by reduction in non-fatal MI. But I think an important thing is also that among all the centers, the outcomes were similar along different subgroups and at all the different trial centers. The safety of CCTA in this trial was also assessed, and there was very low risk of complications. The radiation dose was actually pretty good, considering it's also a 64-slice CT scanner. And so I think this shows that even with a 64-slice scanner, you're really able to get good information at a low radiation dose. One of the interesting things that I think you can take away from SCOT-HEART is that of those 48 patients that had the primary endpoint of death from coronary disease or non-fatal MI, 20 of them either had normal coronaries or non-obstructive disease. Essentially half the population that ended up having either coronary death or non-fatal MI had non-obstructive disease. And I think that's an important clinical diagnosis, and it has important downstream implications on management. And so I think the other thing that SCOT-HEART showed is that initiation of these preventive therapies, aspirin, statins, anti-anginal therapies, they were better in the CTA arm, which I think is an important thing to, we want to be prescribing appropriate medicines to the appropriate people, and I think SCOT-HEART definitely showed that, and it showed that those prescribing patterns persisted even up to 5 years. Now, testing in the short term is going to be higher in CCTA, and I think that's what SCOT-HEART clearly showed. But when you look at long term, the difference in revascularization, the difference in referrals for Cath are going to essentially be the same. In fact, in the CTA arm here, it's not statistically significant or significantly different, but in the CTA arm, it was actually lower at 5 years. And so based on that, the conclusions I want you guys to take from this, among patients that have stable chest pain, the use of CCTA in conjunction with standard of care resulted in lower rates of death or non-fatal from coronary disease or non-fatal MI, without resulting in a higher rate of revascularization or referral for angiography. It also appears to have positively led to alterations in management and treatment outcomes when compared to that standard of care alone. And so again, I think in my opinion, it is helpful in appropriately allocating those therapies, the preventive therapies, and I think it also is going to help refer patients that are more likely to benefit from revascularization. Some of the other discussion points and critiques from SCOT-HEART, again, I don't think it's necessarily reflective of contemporary practice. The difference in outcomes, was that just the result of a suboptimal management strategy? The other thing, again, I think that's important to reflect upon, it's really in a trial of diagnostic testing, it's not the test, it's the downstream management of the test that's presumably driven by those results that's affecting outcomes. And I think we clearly saw that, in SCOT-HEART where, in the CTA arm, aspirin use increased after CTA, whereas, after exercise EKG, it decreased in the standard of care arm. And so to review the AUC in the context of stable CAD, among low to intermediate risk patients with stable chest pain, it's essentially considered appropriate. It's uncertain in that cohort where you have low pretest probability, an interpretable EKG, and they're able to exercise. The other kind of little take-home point that I wanted to throw in here was also the value that coronary CTA can have in kind of the new evaluation of cardiomyopathy, where it's appropriate in both low and intermediate risk patients. And I think those are patients that really should undergo CTA to exclude, 3-vessel or left main, prognostically important anatomic disease that would explain their ischemic cardiomyopathy more so than coronary angiography. And so how does this differ, how do our appropriate use criteria differ from some of the recommendations out there across the pond? Well, the NICE guidelines, which are essentially clinical guidelines used in the United Kingdom, actually have coronary CTA as the test, the first choice test. So anyone where you think your clinical assessment suggests typical or atypical angina, CTA is your first line. Even in patients where you think, oh, this is non-anginal chest pain, but they have abnormal findings on their EKG, the recommendation would be for coronary CTA. And this is, interestingly enough, independent of a pretest probability. That was eliminated from decision-making in these guidelines. So a different way of doing things, but I think certainly interesting and provocative way nonetheless. And again, I want to highlight, I think, the importance here of what we find on CTA compared to functional tests in that, again, almost half of those patients that had hard endpoints of coronary heart disease, death, or non-fatal MI had non-obstructive disease, and that's a population that we're not going to necessarily, we're unlikely to identify on functional imaging. And similar findings were shown on a subgroup analysis of the PROMISE trial, where again, in that CTA arm, about 2/3 of the people that had MACE had it in the context of non-obstructive disease on their baseline CTA. Subsequently, I want to talk a little bit about plaque characteristics on CTA, and the question being, are there certain characteristics that can provide additional risk stratification to even further target therapy? Some of these things have been kind of well reported in the CT literature, and they have pathologic correlates. Positive remodeling, where you see kind of outward expansion of the lumen, low attenuation plaque, spotty calcifications, and what we call the napkin ring sign, which is kind of the pathologic correlate of a thin capped fibroatheroma, all suggestive of increased risk. And so there was a post hoc analysis of the SCOT-HEART cohort that looked at the incidence of adverse plaque and the prognostic value. And so what they found among patients in the CTA arm, about a third had adverse plaque. These patients were more likely to be older, male, all the typical things you would expect, have higher calcium scores. And certainly what we could take away from that is adverse plaque increased your risk to have either non-fatal MI or coronary death 3 times. And when they further analyzed that, it's interesting in that this is looking at normal, non-obstructive, obstructive disease. You can see how these groups kind of layer out. But when you further assess them by both stenosis severity and by the presence or absence of adverse plaque, you see that there's really, non-obstructive disease with or without adverse plaque essentially behaves the way obstructive disease without high-risk features. Really, the risk, the patient that's most likely to benefit and has the highest risk of an adverse event is that patient that has both obstructive plaque with high-risk features. And so I think really this is that group, if we can target it, that we really want to target the most for referral for Cath. Now, interestingly enough, when they did multivariable analysis of that, it was not independent. So those high-risk plaque features were not independent of coronary artery calcium score. So the only independent predictor of risk for adverse events in this cohort was coronary artery calcium score. And I think that really goes to further show that the predominant factor that governs patient outcomes is that overall atherosclerotic burden. Next, I want to quickly turn to CTA in the context of acute chest pain. And so obviously acute chest pain comes with a very low referral threshold. It's one of the banes of the existence for ER providers downstairs. It's a very common complaint. About 6 million people come to the ER annually with complaints of acute chest pain, and the traditional way of how we've cared and evaluated for these patients has been thought to be inefficient. It overcrowds emergency departments, and it leads to unnecessary admissions. And so the first kind of observational study was the RAMACAT trial, or observational study, and that was looking at ER patients that showed up with acute chest pain and no known history of coronary disease. They had initial negative biomarkers and no evidence of ischemia on EKG. All those patients underwent CTA. Half of them had no evidence of coronary disease. In that population, the sensitivity and negative predictive value of acute coronary syndrome is 100%. And so essentially, you're helping facilitate safe and early discharge in those lowest risk patients much faster than if they underwent a stress test the next day or after the weekend. And so subsequently, they actually did a randomized control trial looking at this. And so the authors, their hypothesis was that a CCTA-based evaluation was going to improve the effectiveness of clinical decision-making compared to the standard ER evaluation among those patients with chest pain suggestive of ACS. Here are the inclusion criteria and exclusion criteria, kind of a cohort population you would expect, someone that had had chest pain for more than 5 minutes within the last 24 hours that warranted in their clinical assessment further risk stratification. Again, risk exclusions, anyone that had prior coronary disease, someone that had, definitive acute coronary syndrome at baseline, obviously renal issues, cocaine use, and our primary endpoints, length of stay, both rates of missed ACS within 72 hours, MACE within a month, and peri-procedural complications. There were really no significant differences in baseline characteristics. The overall discharge diagnosis of acute coronary syndrome was low and similar in both arms. And that was predominantly driven by a diagnosis of unstable angina. I think that the take-home, the finding was that when you looked at median length of stay, it was significantly reduced in the CTA arm versus the standard of care arm. And that also held true, obviously, in those that were diagnosed with ACS, length of stay was going to be washed out. But among those that had a discharge diagnosis other than ACS, which is a large majority of the patients, again, you're going to positively impact the time that they're in the ER or in the hospital. And so this is a nice graph depicting that if you look at, at essentially 9 hours, half the CTA arm was discharged from the emergency room. Whereas when you look at the standard evaluation arm, only 10% of that population was discharged within 9 hours. About half of the patients in the CTA arm were actually discharged from the ER as well. Safety endpoints, again, in either arm in this, I would say, lower risk cohort for ACS, there were no missed events of ACS. The two peri-procedural complications in CTA were one an AKI related to obstructive hydronephrosis, and the other was someone that actually had an anomalous coronary and underwent a bypass surgery but had some perioperative bleeding. There was a slight increase, not significant, but increase in follow-up of MACE within the standard arm versus the CTA arm. And in both of those patients that did have MACE in the CTA arm, it was in the context of having clinically significant obstructive CAD on CTA, but negative stress tests. So that's the good. Here's kind of the bad. Certainly it leads to overtesting. It leads to higher rates in this cohort in a short interval of higher referrals for coronary angiography and higher rates of revascularization. Radiation exposure was also higher. Now, when you look at radiation exposure of kind of fair modalities, CTA to SPECT, the CTA arm did have a slightly reduced radiation exposure, cumulative radiation exposure dose. Costs were essentially identical. It was actually slightly higher in the CTA arm than in the CTA arm. Than in the standard of care at the index visit and within 28 days. So 4289 versus 4,060. So kind of a washout there. So take-home points here, use of CCTA in ER patients with acute chest pain. It's safe in, I believe, the low to maybe low intermediate risk patients. It improves clinical decision-making and disposition, efficiency in the ER. It comes with an increased cost of resource utilization and not really any cost savings. And I think one of the disingenuous findings on this study was really patients were only eligible for enrollment on weekday daytime hours. And I think that's, if you're really going to be positively impacting ER triage and disposition, I think it has to be something that you're doing 24/7. And I think the other really important question is with ultra high sensitivity troponin assays coming, what is that impact going to have on the role of CCTA? And there was actually a trial called the Beacon trial, which showed that it still positively impacted timely discharge, but not as pronounced as in Ramacat. And so to just review the appropriate use criteria for ACS, certainly someone that has definitive MI, whether it's STEMI or high risk NSTEMI, someone that it's an inappropriate test. Really, I think where it is appropriate and useful is in those, again, low to intermediate risk patients that either have completely normal studies, an uninterpretable EKG, or very commonly, and I think a niche that we're going to find increasingly so with these ultra high sensitivity troponins is oh, great, someone's got a troponin of 0.2, I don't know what to do about this. I really don't think it's obstructive coronary disease, but I'm compelled to further evaluate. Lastly, with the last couple minutes here, there's obviously some interest in the role of triple rule out, meaning, getting a scan that's going to rule out obstructive disease, dissection, PE. I think this is kind of a less desirable test. You have a trade-off here. One, you're going to give them significantly higher radiation dose, a significantly higher contrast volume. You're going to lose your diagnostic yield in identifying obstructive disease at the benefit of slightly increasing your diagnosis of dissection and PE. It's a more technically challenging scan. It's a longer scan time, meaning the patient's going to be holding their breath longer, and so obviously you're going to get sometimes issues again with your sensitivity and your diagnostic yield of CT for coronary disease. And so this is kind of just the protocol. It's essentially double the scan, higher contrast volume, and different timing of when we actually trigger the scan. Last slide, just kind of food for thought. I think this is kind of where CT is heading, and I think this could probably be a talk in and of itself, and so I really just wanted to leave it to the end. I think the promise, and I don't think we're quite there yet, but the goal is really how do we increase the specificity and the positive predictive value of CTA, and how do we get that to correlate to ischemia? And that's through this use of CT-FFR, and again, integrating anatomy and physiology with hopefully even further decreasing the needs for invasive coronary angiography. What are the issues currently with CT-FFR? It's a proprietary technology, and so the how-to and what is going on behind the scenes is not necessarily all that well. It's kind of a black box. Billing is very problematic. So the way their billing structure works is they actually bill the hospital, and then the hospital is supposed to bill the patient. And so that's obviously viewed much less favorably in a lot of places. And then also there's a lot of grunt work from IT and having a direct link of sending the scan from the PACS to heart flow. There's a lot of HIPAA issues with that, and so I think it's where we're going to get to, but we're not quite there yet. And so with that, if we have any time for questions, I'm sorry for running a little over.
For me. I guess my question quickly on the Scottish trial, if the proposed benefit of the CTA arm was it identified these non-obstructive at-risk individuals, and theoretically got them on medical therapy and then reduced subsequent non-fatal MIs and possibly fatal MIs in the future, would a trial where you had enrolled the same group of patients in a calcium score ended up with any different results?
That's a great question. I think it would probably, I think the benefit of a calcium scan would probably be pretty similar. I think there is still nonetheless a cohort of patients where you're going to have non-calcified plaque, and is that over a population going to be meaningful? I don't know, but I can certainly tell you there's going to be that 1 to 2% of patients that have no coronary calcium, have high-risk disease that you're going to miss. And I think particularly in a cohort with acute coronary syndrome or someone where you're trying to exclude cardiomyopathy or ischemic cardiomyopathy as the diagnosis, where I think that's a bad idea, but I do think that's a valid point.
Great presentation. Any comparison with stress PET?
So interesting, all of these trials did not compare to stress PET. Promise did not have PET. SCOT-HEART, obviously no PET, low referral in the standard of care to any kind of additional functional imaging testing. So no.
Alex, that was good. Why do you think we don't use it here at any of our hospitals? And what hospitals throughout the country might be heavy duty into this in the ER patients?
I think that's a great question as well. And I think it goes back to this whole concept of, you have to rely on what the strength of your institution is. And so, if you're at a place like Midtown, where PET is, essentially like a Cath, the role for it is probably not as needed. But then you go to where we go as fellows at Grady, where basically you get a SPECT from with a SPECT scanner probably from 1970, and you're probably better off just putting them on a treadmill or flipping a coin. And I think that's also a cohort where there's a lot of younger patients, lower to intermediate risk of obstructive coronary disease. And so I think that's really one of the populations that would, and institutions where it would really be beneficial. I think there are plenty of hospitals across the country that run into that same issue where their functional imaging, either stress echo or nuclear imaging, really isn't that strong. And I think this is, a perfect opportunity for this type of modality.
I know some hospital like William Beaumont Hospital, they do a lot of CT-FFR.
Mm-hmm.
And they're extremely, the cardiologists are so happy over there because they think it really reduces the cardiac catheterization.
It does. There does appear to be a good amount, some data out there, and again, I didn't have the time to review it, and I think it could be a talk in and of itself, but there I think is some data that supports that you're going to really help improve the referrals for inappropriate caths, and you're really going to be targeting the patients that you want to be taking to the cath lab.
I think one of the things I saw from the NICE stuff and what I've talked to other UK people about is that they're using CTA because it's available, and the high sensitivity troponins have really caused a lot of chaos in the ER, and it's helped them triage them quicker.
Yeah.
The CT-FFR, I was at a presentation recently, and it seems to be very labor intensive and very operator dependent, and I think it is going to be front and center within the next probably 10 years, but it's if you have an expert who's actually taking this stuff offline and doing all the CT-FFR, it really is very good.
It is, but to your point, when it was kind of discussed at the Hopkins CT course I went to in the summer, sometimes the turnaround time can be, a day. And so, that can, for an outpatient, that's not a big deal, but for an inpatient, is that a problem? And so that is certainly one of the downsides.
Yeah, I was just going to speak Kushro to you. I think that Emory, as far as coronary CTA, is very far behind in terms of our utilization of it. As a test for chest pain, no one throughout the Emory system uses it on a regular basis. For the CT-FFR thing specifically, right now they are saying that the turnaround time is about 2 to 5 hours. They've brought on more readers, and right now they have it 24/7, except for like a 4-hour time period on Sunday morning or something like that. So something that we're trying to get here, both at Emory Clifton and at Emory Midtown.
The preceding program is copyrighted by Emory University.